Wow. All right, welcome everybody to today's webinar on McCormick Mobile. Becky and I are going to give an overview of the McCormick Mobile pilot project that we completed this past year and then talk about future versions of McCormick Mobile. All right.
Welcome, everyone. We're excited to be able to finally share. It feels like a project that we've been working on for a really long time. And I know we have mostly in attendance people who are interested in participating and a few attending from different organizations. So we'll be sure to share in a way that is valuable for everyone. There is the chat box, and we'll keep an eye on that. But feel free to ask any questions there in the chat, and we'll have some time at the end to answer as well. So I'm going to share my screen and we will get started. Okay, you can see my screen okay, Tara?
Yep.
Okay, so McCormick Mobile, individualizing dementia education and enhancing care partner capacity. So my name is Becky Clark, Director of Dementia Services, and we have Tara, one of our full-time social workers from Dementia Services. We're going to start with a powerful video that was created. It was funded by the McCormick Care Foundation, which is our fundraiser. It was the promotional video that was used for the Ritz several years ago, which began the fundraising for the whole McCormick Mobile campaign. So it is a very emotional video, but it was definitely impactful. So let's make sure I shared my sound.
Cold wind blowing through the walls. There's nothing in this world that's ours.
Charlie!
Dark ocean with a tiny flame.
I can't leave him alone.
Somehow we're gonna find our way.
I'm gonna have to cancel my appointment on Tuesday.
All I had was you. Ooh, ooh, ooh. All I had was you. Ooh, ooh. Cold wind.
Okay.
All right. I haven't seen that video for a while, so yeah, I kind of forgot how powerful that one is. Okay, so that, like Becky said, we played that at McCormick or at our the Ritz Gala several years ago when we were doing our fundraising. So that was to kick off McCormick Mobile. So before we get into McCormick Mobile today, I thought we would start with just an overview of some of the stats to give you guys an idea of the number of people that we serve at McCormick. So the first set of numbers here are for the day program. So the number of unique clients who have attended the day program between April and December of this year. So we've had 294 different clients attending in the first 9 months of our fiscal year. And currently, as of the end of December, our wait list was 231 clients waiting to get 1 day a week at the day program at McCormick. And the average length of wait is about 15 to 18 months for those people on the wait list to get a day. Our overnight program, Respite, we've had 93 unique clients who have stayed with us overnight since April of the past year. And just our staffing complement is we have 3 full-time social workers. And so that's Catherine, Sonia, and myself. And our caseloads are between 250 and 300 care partners each. So we have very high number of people that we're working with.
So the number of people that we serve really shows the reach that we have in the community, and we know that there are lots of other organizations that are also supporting people. The way the McCormick Mobile came to be, it's always been an idea sort of in the back of some people's minds of going into homes and providing education, but it was really highlighted during the pandemic. So when we had to close our doors to people coming physically into the day program, and caregivers all of a sudden were left with very few supports, if any at all, coming to their home, all of a sudden care partners, they were 24/7 with their person and trying to figure out personal care, bathing, dressing, grooming. Of course, you're already doing those sorts of things, but just at a whole nother constant level without any supports, and then the recreation component and all of these sorts of things. So the seed was planted during the pandemic, we would say, just figure out what can we do, how can we share our collective knowledge here with the informal caregivers living in the community. So we created this really unique individualized education program for us, our team of experts, to go into the person's home and provide education with the caregiver for the person they're caring for. So the whole mobile program is not to go in and provide a break. What we want to do is provide tools to put in the care partner's toolbox to help them provide that 24/7 care beyond just getting a break from community supports or coming into the day program. The structure of our team is an interdisciplinary team model. So that means just like in our day program here, so our mobile team model included social workers, it included registered practical nurses, so our RPNs, personal support workers, PSWs, recreation specialists, and then a whole research team behind the scenes too, as well as a lot of administrative to support the scheduling and data collection and those sorts of things. So that's a bit about the team and how it came to be. We mentioned the McCormick Care Foundation. So they raised $200,000 for us to do this first pilot study to actually try McCormick Mobile, all wrapped in research. So through the Care Foundation, that fully funded us to do the first version of McCormick Mobile. The really important part of the pilot was the partnership with Western University. So Dr. Marie Savandrayagam and Dr. Anna Garnett were the principal researchers with us, helping us to develop the different measures we'll talk a little bit more about later, but really what we needed to measure, what was the impact of providing this new model to care partners and the person they support in their home. So that was a really important part of the pilot. So because it's an educational model, not a respite model, we needed to take into account the different perspectives from those that we were going to serve. So we have ideas of how we think it would be best, but we needed the input from the care partners as well. So we had 3 different care partners who actually helped us co-design McCormick Mobile. So they were involved in helping us, design different parts of the intervention. So we actually recorded a couple of their stories. So we're going to share Selma's story, who was a caregiver and part of the co-design.
I was living outside of London for a couple of years, just finishing school. And then I moved back to London, and I'm really glad that I did, because that's when I started to notice that, things were changing, or rather progressed with my mother. And before I knew it, I became primary caregiver 24/7. I was experiencing caregiver burnout. Step 1 was just to validate my thoughts and my feelings. And that opened the door to the next steps, right? To look into resources and support and everything else. It does happen in these sort of gradual and subtle ways, and you yourself don't even realize. Sometimes it's just important to treat yourself and just kind of like be conscious of, okay, when was the last time I did something for myself? It's definitely one of the lessons, it took me a long time to learn, that you can't be a good caregiver if you are not taking care of yourself. One of the main challenges is getting my family to understand the gravity of the situation, and that mom does need a lot more help than they might realize. Some people with dementia, they do appear rather high functioning. They can sit here and have a conversation with you exactly like how I'm doing, right? But there's so many other activities of daily living that aren't happening. So it's easy for maybe other family members or people who aren't there all the time to be like, oh, you're just, being rather dramatic about the whole thing, or this is just you being a control freak and you really want things done a certain way, not realizing that the individual just needs a lot more help in those day-to-day tasks. I've always been extremely close with my mom. Prior to her, getting dementia, she was like, the best friend that I tell her everything, and we go shopping and we help each other pick out our outfits, and we had that kind of a relationship. The dynamic has changed, and a lot of things have changed about our relationship, and that's one of the things that I kind of had to come to terms with when I found out about her diagnosis. And now that I've gone through it for a few years, I can see that we are creating these happy memories together, because you can still have them even if that person is in that different stage in their life. It's about keeping an open mind and adapting.
So another, somewhat emotional video there. The importance of sharing the care partner story is everyone's care partner journey is unique, but perhaps there's inspiration or a sort of relation you can have to someone else's story. So we wanted the co-design to inspire other people to be able to accept help or, see themselves in some of those situations too. Other considerations for the design of mobile, really important was adult learning. So again, we learn differently. Some people are visual, some people need to read things. So we designed mobile to have different ways of teaching. So whether it's watching videos, using a printed handbook, meeting with our professionals, and setting goals and things like that. So it was really important for us to go at the education from a lot of different angles to meet everyone's unique needs. We wanted to make sure as well that everyone had access to technology. So we didn't want that to be a barrier for participation. We did record professional videos as part of the funding for McCormick Mobile, and we'll show one a little bit later. But if someone didn't have Wi-Fi, then we would provide them with a tablet with the videos downloaded onto the tablet so that they could access those at any time. Perhaps something was demonstrated earlier in the day or early in the week when the staff was there to do the education, and they needed a little refresh so that they could access that video and replay it and kind of walk through the different steps of what was sort of a strategy that was being taught. So those are some of the unique considerations for the education style of the mobile program.
Okay, so I'll tell you a little bit about what exactly McCormick Mobile is. So in our pilot intervention, it was a 6-week program of education, individualized to the care partner's needs, provided in-home and with follow-up calls. So week 1 involved the social worker coming out to do a home visit. And it was really a very thorough assessment week 1. So we would go and ask you lots and lots of questions, get all of the background information on the person that you're caring for, as well as really focus on goals and what your goals are and what you want to learn through McCormick Mobile. So it's very individualized. We've had people, who the diagnosis is fairly new, so they're early in the disease process, right through to people later in the disease process. And we're able to tailor the intervention to any of those stages. So during week 1, we would set those goals. One of the things we actually found, because we had an idea of the things we were going to be teaching all of these weeks, but one thing we found doing the social work assessments was that people sometimes didn't really know a lot about the disease. And we'd kind of forgot that in our planning. So in week 2, the social worker went back out And the plan had been that we would be focusing on communication strategies and then strategies for how to cope with different behaviors that you're dealing with. And we did do a lot of that, but we also added in disease education. So if someone had a diagnosis of Lewy body dementia and knew nothing about Lewy body dementia, we would make sure that we would bring education, information, and resources about that and kind of start there. So really, we start where you are, and we provide the education on what you want to learn about. So week 3 was the registered practical nurse. And again, we kind of thought medication training, delirium training, that type of thing is what they would talk about when they went out. And then week 4 is the personal support worker, and they went out to provide assistance with activities of daily living. If people needed help, how do you transfer someone, that type of thing. So all the kind of hands-on assistance with daily living activities. And again, what we learned when we went out is that sometimes people didn't need necessarily a whole visit from a practical nurse and a whole visit from a personal support worker. So fairly quickly into our pilot project, we condensed those visits into one. So the practical nurse and the personal support worker went out together and did the visit together, which I think was more successful. And then week 5 was the recreation specialist. And they went out to the home to be able to provide, information on how do you engage someone in meaningful activities at home? Because I know a lot of people always tell us that they won't do anything for me at home, right? They come to the day program, they participate in everything, but at home, I can't get them to do anything. So the recreation specialist would go out and provide education on that. And I think this was one of the most popular visits out of the whole week, 6-week program from what we heard. So that was week 5. And then week 6, social work would go back out to do a wrap up as well, to focus on self-care. So we know that that is so important for care partners, but it's sometimes the part that is missing. So a focus on self-care, connecting care partners to other resources. So if you're not, already connected to us for support groups or education, making sure you know about those things, as well as other community resources. So that was the layout of the 6 weeks. And you would get the home visit would be typically on Tuesdays is what we did in the pilot project. And then whoever was out on the Tuesday would do a follow-up phone call on the Thursday or Friday that week, just to make sure, see if you had any questions, kind of had some time to think about the things you'd learned, and follow up that way. So it was a home visit and a phone call each week.
I briefly mentioned in the beginning about our interdisciplinary team. So we had our social workers, so both Tara, Sonia, and Nancy all participated in the home visit. So they would be assigned to a particular family and follow them through the full 6 weeks. So we just divided that we had 10 participants in the pilot. So they each saw a different family. Allison was our RPN, and Lindsay as well ended up doing home visits. Heather was our PSW. From recreation, we had Jane and Heidi doing the home visits, and they both have a lot of experience. So that was a really wonderful opportunity for them to be able to go and do something different. We'll talk about the learnings later, so I won't get into that from a staff perspective. And then, of course, lots of support behind the scenes, like I said, for scheduling, for the coordination. There were a lot of details, especially with the pilot. We were able to make tweaks all along so that we weren't really stuck in a program that we thought was going to work from the beginning. We could make these little changes all throughout, and that was right from some of the research protocol portions, like Tara said, to the intervention. And I mentioned our research partners as well. So that was our team. So the next team may be similar, but still the same complement of disciplines. Here are just a few screenshots of the workbook that we created. So this was something that took us a lot of time to develop because we were doing it sort of at the same time we were doing a lot of other things. The one really important piece with the workbook is that we wanted it practical. So we're going out to give the education, and how can we have this tool as like the doing part? So what are the things we really need to provide to the care partners? So it was a physical book. It was also available for PDF download if someone preferred that type of format. And in the PDF, it meant that all of the videos were actually a hyperlink, so they could click onto that if they had that Wi-Fi connection. They could watch the videos embedded right there in the book. And then each section also had a goals page as well. So that just reminded us to, really think of what are your needs and how are we going to get there, and reflect on that, which is a really important part of the adult learning process as well. Anything to add, Tara?
No, I think that covers it.
Yeah, so we provide the book. It's different sections based on the different disciplines that are visiting. We mentioned we were funded to create professional videos. So we actually rented an Airbnb and sent our staff and an actor into this Airbnb home to grab these videos. I'm just grabbing the link here. So this is an example of one of those practical tip type videos that we produced.
When helping to change an incontinence product for someone with dementia, it is important to preserve their dignity throughout the process. Whether this activity is being performed in a public or home space, ensure it is private and comfortable. If in a public setting, family washrooms provide more room for two people to effectively utilize the space. The process being shown in this video is how to change an incontinence product with the individual's pants still on. This can be done if the person gets cold easily or is unsteady with standing. To change the product, begin with the person sitting down. Lift one of their feet and slide one side of the brief over their foot. Next, with their pants at their ankles, grab the brief through the pant leg and pull it up through their pants. Be sure to keep the product straight. And then feed it down through the other pant leg and pull it over their other foot. You can then slide it up and properly adjust it onto their body. To remove the old product, you can rip it at the seams and then appropriately discard it. Remember to ask the person if they are comfortable and warm after you are finished changing their product.
Again, that was just one example of the videos. All of these videos are available on our website and our YouTube page, and we'll share the link to that playlist at the end of the presentation. So these are public access now, so might as well share them. Okay, so Tara talked a lot about the intervention, so us actually going into the home. But once someone is participating in the research project or the intervention, what does it actually look like? So I had mentioned that there's a big research focus. We're looking at both the client and the care partner's needs as well as their well-being. So, things like caregiver distress, burnout, ability to cope. We'll talk about a few of the preliminary results a little bit later. So with it being research, there is a bit of a commitment up front to get some pre-measures and then participate in the intervention, and then again, some research on the back end. So this looks like, so we have a pre-evaluation, and it's done in two parts. So there's a questionnaire that gets mailed out to the care partner, and on your own time, you can go through that and answer those questions. And then the second part is that a researcher will call and do a phone interview to ask a lot of open-ended questions, and this is more of that qualitative data, and an early start on discussing some of the goals just to give the social workers a bit of direction on their first visit. So that's a pre-evaluation part of the research. And then we do the 6 in-home visits and the follow-up phone calls. So it's 5 weeks in a row. And then we have the post-evaluation. And then we have a new this time around, a 6th visit 6 weeks after the final. So just sort of that 6-week follow-up to see how are things really going? Do you have more questions? Has anything new come up? What have been your successes? Then, as again, part of the research, the post-evaluation, same questions are asked, tweaked a little bit, but again, done in 2 parts where there's a paper questionnaire. You'll return that by mail. And then again, the researcher will phone you and discuss more of those open-ended questions. So we did tweak some of the pre and post evaluation questions just based on our learnings and based on the outcomes we'd like to measure. So including things now like maybe hospital visits, diversions from emergency department and those sorts of things are important for us to look into.
Okay, so for the pilot project, we carried out McCormick Mobile with 10 care partners and the person that they care for. So it was a fairly small sample size, but that's what our funding was for the first time around. So of those 10 people who participated, 5 were people who currently attend the day program, and 5 were people who are on the wait list for the day program. And then just a little note about some of the documentation throughout the project. So lots of assessments, like I said at the beginning, so lots of documentation there. And then every visit that the staff did, they would document fully when we got back. As well, staff did their own journals and their own reflections because we also wanted to get feedback from the staff who were participating in this. How are things going? What went well? What didn't go well? What did we need to, kind of make changes to? So the staff kept their own journals. And then we had weekly team huddles. So every Thursday afternoon, all the members of the mobile team would get together and give updates on our visits those weeks. And again, what were we learning? What, adjustments needed to be made, those type of things. All right, so early results, and some of these are hot off the press as of yesterday, some of these results. But yeah, so kind of like I referred to a second ago, the study involved not only the data collection related to the participants, but also the team members. So we wanted feedback from, the care partners, but also from the team that was out providing the service. And like we've kind of referred to being a pilot project, we were able to make adaptations as we went along. So once we figured out, maybe we don't need the nurse and the PSW going on 2 separate visits, we can put them into one, we were able to do that. Again, small sample size, so it is hard to generalize all of the results, but what we did get from the 10 people that we worked with has been, I'd say, fairly informative and positive reactions. And the really good data is the qualitative data. So, the surveys they send out, the questionnaires, that you tick off the boxes and all the scales that you rate, that's great. But really the qualitative data where we hear the stories of the people who participated is the real kind of gem of the results. And then the findings that we just got back yesterday, so this again is preliminary data from the researchers at Western. So what they did find was that objective burden decreased. And objective burden is the feeling that you don't have any time for yourself because of caregiving. So that kind of idea. And so we found that decreased after people participated in the project, which is what we would want to see. We also found that caregiver competence increased. Again, this is what we want to see, right? We're teaching you new tools, providing education on how you can cope better at home. And so we found that caregivers felt more competent after they participated in the program. And then finally, self-efficacy for obtaining respite improved. So people were more likely to obtain respite after the program. And that might be why their objective burden decreased, because now they had some respite care coming in and they were able to get a bit of a break. So we were pretty excited to hear those results yesterday, and they're what we wanted to see. So it was good.
Thanks, Sharon. So just sharing more of those sort of qualitative comments and things too. So we asked people, why are you interested in participating in McCormick Mobile? Like we said earlier, everyone's caregiver journey is different. So the reasons for participating were different, but a lot of people just looking for help planning the future. So sort of feel okay now, but what should I be expecting and how can I be a little bit more prepared? What can we do in the home? We just want to learn as much as we can, get the information and see if there's anything that we can be doing. And then a lot of people, or there were people who said, I just want to do it to help you out. So by my participation, does it help inform you as an organization and how you can make the program better? So there were different reasons for participating. And again, only 10 people. What is the most pressing concern is something we asked. So again, how will this disease progress? What should I be doing? How long will I be able to care for my person and keep them home? Will I be able to keep them home until end of life was a common question as well. After the intervention, we asked sort of what about the training was most valuable for you? And again, everyone learns differently, but we kept hearing from a lot of people, training in their home was a game changer. And we heard this from the staff too. So, you know, when people come to the program, who we meet and, you know, maybe some of the experiences they have are quite different than at home. And what is it like in the person's home, sort of 24/7, seeing their environment? We could really fast forward the relationship and really get into their unique needs and create that training program really on the fly in the moment. So that was really valuable to be in the home and just develop that strong connection and trust. And then, like Tara had mentioned earlier, the recreation was something that people hadn't really thought of, but they really learned a lot from that. So yeah, and again, everyone's needs were different. So what mattered to people was all different.
All right, and then some comments about the variety of team members. So again, people thought it was quite helpful to have, you know, it's not just the same person coming every week for 6 weeks, right? It was a variety, so they got different perspectives. So the social worker, the recreation therapist, the nurse, and the PSW, and got to learn different things from each of those disciplines.
And we love the thoughts from the team. The huddle, the weekly huddle was really, really valuable just to share our learnings, to help people prepare for their next visit or their follow-up. One of the things I didn't really anticipate, but just how important it was for staff to have a new opportunity, especially coming through the pandemic and maybe being tired or, you know, doing the same tasks repeatedly. This was an opportunity for them to be challenged in a new way, to go into people's homes and really show their skills. And I think a lot of the staff were, well, some of the staff were surprised that they knew as much as they did and they could help people in such a really, like in a big way. So that was, I think, really important, you know, as managers of teams, how do we have team members who are satisfied with their job and feeling that purpose too. So that's really important. People loved being in the home environment. And then a comment too that we just really hope to see the model continue to progress. It's definitely a valuable framework that meets people's individual needs. And that's just what things kept coming back to. It's the individualized needs and our approach that made things really successful for that group of participants. Okay, so we're already talking about the next step. So like we said, pilot was our first launch of McCormick Mobile. That was totally funded through McCormick Care Foundation. So printing the books, developing the books, all of that stuff, staff time, mileage. So that is all wrapped up. We finished in homes in September of 2024. So we're moving on to the next version of McCormick Mobile, which is really, really exciting. So again, with our partners at Western, we were able to secure funding this time from Petro-Canada Caremakers Foundation. So together with Western, we applied to Petro-Canada for this grant opportunity, and they awarded us funding for us to be able to do McCormick Mobile 2.0. So right now we're just working with Western to get new ethics submitted, and we'll be looking at launching mobile really as soon as the ethics is approved. So in the next month or so, which would be about probably early March 2025. So again, it's wrapped in research. It's an opportunity for us to make further improvements and changes to the model, to measure different outcomes, again, to tell a story, the return on investment, the impact in the community, and those sorts of things. So we're really, really excited to be working with Western again and have funding from Petro-Canada this time to make more impact in the community.
All right, so here's a few of the details about McCormick Mobile 2.0. So in order to be eligible to participate, you have to be accessing McCormick Dementia Services. So it's not open just to the general community. You have to be connected with us. So that can look like a few different things. It could be that your person currently attends our day program, or it could be that they're on the wait list for our day program. Or it could be that you as the care partner are receiving care partner supports. So maybe your person is not in the day program, they're not on the wait list, but you are coming to a support group, you're coming to our education, or you're getting support from one of the social workers, you would qualify. The person must be living at home in the community. So they cannot be living in long-term care, and they can't be in a transitional bed. And a transitional bed are those beds where people go if they've been in hospital and they're waiting to go into long-term care, they may go to a transitional bed. So you don't qualify if you're in long-term care or the transitional bed. And then everyone who is interested, there will be a kind of pre-screening process for suitability. And one of the things that we look for in the pre-screening process is you also cannot be on a crisis list for long-term care. So you can be on a regular wait list for long-term care, that's fine. But if you're on a crisis list, which means your person could be moving into long-term care at any time, then you wouldn't qualify because we don't want to get partway through the intervention and then not be able to continue it. All right, so timeline, like Becky said, we're hoping to be able to launch this early March, and it'll continue for a year. And this time the number of participants will be 40. So quite an increase from the 10 from last time. So we're excited about that. And then the other new thing this time is that we're going to have a control group. So this is a research thing. So we're all learning about this as we go. So a control group means that half of the people who participate, so 20 of the 40 that we're going to do, will be assigned to the control group and 20 will be assigned to the intervention. Everyone will get the intervention. So even if you're in the control group, you will get the intervention. But what it means is in the control group, you would do the pre-research questionnaire and the pre-research interview. And then you would wait 6 weeks with no intervention. You would redo the questionnaires and the interview. And then you would receive the service for the next 5 weeks and then continue on as normal. So they just want to judge, in those 6 weeks, is there any change compared to when you actually get the intervention? So it'll be random, you'll be randomly assigned to either the control group or the just the intervention group. But like I said, everyone will get the intervention. You just have to wait 6 weeks if you're doing the control group and have to do the questionnaires an extra time. So the intervention, when you get there, everyone will have to do the pre-research questionnaires that get mailed out to you, as well as the phone call with the researcher for the open-ended qualitative questions. You'll then receive 5 weeks of the interdisciplinary in-home visits with a weekly phone call every week. You'll then do the post-research questionnaires and phone call with the researcher. And then the new thing this time is that we have a 6-week follow-up visit from the social worker. So it was kind of hard last time because we just ended it after the 6 weeks, and then there was we never knew how anyone did afterwards, right? So this time we're gonna go out after 6 weeks and see, have you been able to use the skills that we've taught you? How are things going? Do you have other questions? And yeah, some follow-up. And then cost, there is no cost to you to participate. All right, so how do you register? So you can email the research department at McCormick, and the email address is there, research@mccormickcaregroup.ca. So you can directly email that, or you'll be connected with one of the social workers, so you can let Catherine, Sonia, Nancy, or myself know, and we can send your information to the researchers as well. And if you want more information about the McCormick Research Plan, that is our website, the link right there. You can go on and have a read through that. And you can email right now. So even though the project hasn't started, we are kind of starting a list of people who are interested. So if you do want to participate, please let us know and we will sign you up for the research project.
Yeah, so a big part of doing this webinar, we obviously wanted to share what have we been up to with McCormick Mobile, but we found that our participants last time were really overwhelmed. What actually is mobile, and what am I signing up for, and what does it look like? So we wanted to be able to provide this even as a recording for people to refer to really get hopefully a better understanding of what is the research, what is the intervention, what are we looking for, and how can it benefit you as a care partner, or a potential partner organization in the future to use this type of an education model. So hopefully this is helpful. We will, once we have ethics, be doing official recruitment. So you'll see promotion through email, our social media, on our website. But like Tara said, if you are interested or you know someone interested, then you could email us now and we'll start you on a list. So what are the long-term goals of this type of in-home individualized education? We'd really like to demonstrate this as a really successful means of providing care partners the tools to keep their person safe at home as long as possible. So there's a real focus to keep people living in the community. It's more economical from a funding perspective to support people at home versus living in hospital or long-term care. And I think most people, when they're thinking about their future, life, they'd rather be thinking about living at home than living at long-term care. However, there are times where long-term care is just needed. So we'd like to, demonstrate that we can help support all of these informal caregivers and help them sustain even good quality of life for themselves and the person they're supporting by investing in them as care partners. Of course, we'd like to demonstrate the strength of the interdisciplinary team. So here at McCormick, we're very proud of the different disciplines that we have. So again, social work, nursing, recreation, research, administration. So we really feel that it's the different skills and experiences that our different team members bring to our team and this type of program that really makes it a promising model. To reduce ALC, so alternative level of care is, sort of a program to transition people out of hospital who don't really have acute needs and don't really need hospital care, but the care partner, or for whatever reason, can't safely support them living at home. So that's a bit of a transitional time where someone may be living in an ALC, or like Tara mentioned, those transitional care beds waiting for long-term care. So is there any way that we can demonstrate that, again, by investing in the care partners, strengthening their abilities, that we can reduce some of those ALC burdens, and we'd really love to reduce people having hospital visits. So whether that's by preventing falls or deliriums, different things like that will be interesting to see. Another long-term goal would to be receive permanent funding. So right now we just keep getting some grant funding, which is really fantastic to have that support. But we're hoping that the research will demonstrate the value, again, of this investment in those informal care partners that are living in the community. And another goal, we'd love to, in the future, partner with other organizations and help you implement this model of education in the communities that you serve. Karen Johnson and I presented at the Ontario Community Supports Association conference this past fall. And it was interesting because not all the participants at that conference were supporting people living with dementia. And we were so focused on that type of population and just obviously realized this model applies to supporting, various needs, right? Whether it's, special needs, adults living with disabilities, brain injury, whatever it may be, we really feel like it's providing that specialized education based on their needs that supports their caregiving needs. So that's something that we'd be looking at in the future as well once we fine tune and tweak our program a little bit to share it with others. Okay, so that brings us to the end of our presentation, and we'd be happy to answer any questions or hear your comments. And again, I'll just share this slide. This is our YouTube playlist that has all of our professional care partner education videos on it. You will see a different playlist with some other more homemade ones that we made during the pandemic. And we just used some of our funding to make these ones a little bit more professional. So I'll stop sharing my screen. We can see if there's any questions.
So if you have questions, feel free to enter them in the Q&A box. Sometimes the chat box doesn't work in the webinars. So there's a Q&A. So if you move your mouse or touch your screen at the bottom, there should be a little question mark that says Q&A, and you can enter any questions that you might have in there. And if you think of things afterwards, feel free to reach out to Becky or myself. We'd be happy to provide you with more information.
Just popping a couple links in the chat there. So that's the link to the page on our website that has more information about the research. And then I'll put in our YouTube playlist as well. If you'd like to access those videos or share them among your networks, that's perfect as well.
All right, so question here. So after the 6-week follow-up, what continued access would we have as caregivers? Good question. So yeah, our hope is that through this process, you'll now have a really strong connection with the social worker and the team that have been out visiting you, right? So definitely, whether it's your social worker who comes to see or you're connected to one of the other ones, absolutely. Ongoing social work support, access to caregiver support groups, access to the caregiver education. We want you to participate in all of those things and feel that you can reach out to us at any time. And then depending on your needs, we'll also help you to connect to other community agency resources or to Ontario Health at Home, or what would be applicable for you as well. So yeah, you're not dropped at the end of the 6-week follow-up. Absolutely not. Our goal in this is to build strong relationships so that you're better connected to us and our team, and that we are here to help you on an ongoing basis. It's just the research part is over after the 6-week follow-up.
I think this is obviously a really great question. Tara answered it well. It just reminds me, this is feedback we heard from the participants, is that they finally felt like they had someone in the whole system to help them. Like they had an anchor, like now I have someone. And it, when you send referrals to a bunch of places and you get different letters and phone calls, it's just kind of like, it's a lot. And now that you've met the people in their home, the relationship is just so different. So they just felt so supported ongoing to have that connection.
And then we had a second question very similar, so I think we've answered that. And then I think this one is that the person is currently in the day program. Does this get impacted by partaking in this program? Do you want to take this one back here?
Sure. So it doesn't affect day program attendance in any way. In our pilot, our intervention days were really structured, just the way we had to coordinate our staffing. But in our next intervention, so let's say the person comes to the day program on Monday, Wednesday, we would just schedule the home visit on alternate days. We have some control over our schedule, so we'll make it work with your person. But in no way does it impact, any day program attendance. I feel like it actually enhances their day program experience because, again, we're learning more about home life and how we can, with your consent, share some of that information back to the rest of the day program team. So there's a lot of value.
And another point about that too is that we've actually found, so the idea at the beginning of this was that the care partner and the person living with dementia would both be present at every visit. However, we found there were some challenges to that, especially with some of the social work visits, because sometimes it's really hard for you guys, the care partner, to talk freely when your person is right there. So we will work with you around whether or not you feel comfortable having them there, or whether or not it would be better to do it on a day when they're actually in the day program, at least for those social work visits, right? So we will adapt the schedule according to your needs and work with you around that. But yeah, it won't impact them. They won't lose days at the day program. We will make it work. How do you work or will work with different communities or cultures?
I think that's a great question, and it's something that we were thinking of when we were developing it. So, is the workbook translatable? If it's digital, are there different ways that someone could access that information, even the videos, using subtitles to help with translation? I think what's really important with the model is that it's individualized. So we're going to you, and as a care partner, you can help inform us what's important to you. So if there are different cultural, religious values or preferences, you teach us, and we can adapt, hopefully, our training to meet your individual needs. So I would feel like that's one way. Tara, do you have other thoughts?
Yeah, I think that covers it. Yeah, I think our idea was like someday we would be able to have the workbook done in all different languages and translations. So I mean, we're not at that point now, but I think it's something that, yeah, we would like to, do in the future as well, right? Have it available in different languages.
Yeah, and I think even once we partner with other community organizations, we would take their lead. So it's like, here's the model, sort of the skeleton structure of it. You are the experts for this community that you support. So even if it's working with an indigenous community, so you support them now, how can we make this model fit with, the community that you support? So that's our goal, that it's adaptable.
Right. Any other questions?
Great questions.
Yeah.
Yeah.
All right. I don't see anything else coming up, so I guess we can leave it at that for now. But like I said, if you guys think of questions, please feel free to reach out to Becky or myself. We'd be happy to provide you with more information.
Okay. Thanks for tuning in. We hope that this helps answer some of those questions, and we hope that we can help support more people with mobile. Okay.
Thanks, everybody.